There are a lot of options. We have more tools than we've ever had before. We can try different things, we can take different approaches. As a field, we're innovating. And so, as individual psychiatrists, providers, we can try a lot of different things for that patient who feels like they've tried everything.
Hello and welcome. We're so glad you're tuning into the Taking Good Care show. I'm Dr. Andrew Wong, based in Toronto, Canada.
And I'm Dr. David St. Arnaud, based in Edmonton, Canada. We're two practicing psychologists with over a decade of experience each, working in a variety of settings and supporting diverse populations.
Thanks for joining us. We hope you enjoyed today's episode. While we're both practicing psychologists, our podcast is intended purely for educational and entertainment purposes. It's not a substitute for professional mental health care or treatment. If you're in need of support, we strongly encourage you to reach out to a licensed mental health professional in your area.
All right. Good morning, everyone.
Good morning. We are back. Really entertaining morning so far. Troubleshooting technology. That's always fun. But we're really excited. Our very patient guest is a returning guest, Dr. Michael Martyna. He is back, and we're so happy to have you back, Mike.
Yeah, it's great to be here. Thanks for having me back on the show. I had a great time the first time, and I'm a big fan of the pod.
Awesome. We're not going to spend a lot of time introducing Michael because you can go back to the previous episode where he introduces the listeners to psychiatry in general. And then today we're going to be more focused on depression and treatment for depression. We were brainstorming this and leading up to the holidays. I know the holidays are not always, jolly and happy for everyone, even though that's the commercials we see and the kind of the atmosphere we have. Actually, I'm wearing this like ridiculous sweater vest right now. I thought maybe that's what broke the internet this morning. But yeah, I think we're going to look at depression, and I think it's timely. So Michael, we're going to dive right in, especially we're running behind in time and we want to be respectful of your time. I know you got a lot on your plate. So maybe just give us a quick kind of overview of depression and then point us in a direction, and then we'll have some questions.
Yeah, so when we're talking about depression in this kind of clinical context, we're not talking about just like feelings of sadness. Some people might say like, oh yeah, that kind of, like that depressed me. But when we're talking about it, it's, because sadness is normal, it's a part of life. But when we're talking about depression, something that we're going to treat, something that, people need assistance with, it is common. It's also treatable, and it's highly individualized, both kind of how it looks for the person and then how we treat it. Sometimes when people are depressed, or when they think about depression, if they've seen it in others, you might notice things like a person does just feel kind of like gray, blue, sad, and it's not just for like a day, but it's probably for weeks at a time. And it's not just an emotional component. Like people's thinking patterns can change. So feeling worse about themselves, feeling generally kind of negative about the world. And then sometimes people will notice that they're then withdrawn. The things that they used to really love and get pleasure from, the kind of like that zest or spark might be gone. So then the motivation to do things isn't there. So then they are just doing less. That can impact socialization, that can impact their work. And then there's other parts of our just physiologic function that get impacted. Appetite can change up or down. The way that we sleep can change. Actually, most common in depression is you get a lot less sleep. It's hard to sleep. And then, like even our concentration, the function of our brain to attend to things gets altered. And so those are some of the things that we can see when people are depressed.
Yeah, and I think one of the key things that you mentioned is that it's prolonged. It's not just I had a bad day and I'm feeling like crap, and then it'll change and it'll fluctuate. A requirement for a diagnosis of like major depression is that it has to be sustained for a prolonged period. So this isn't something that just comes and goes quickly like a lot of our moods do. So I think that's really important for the listeners, even though you might be checking the boxes in terms of like, yeah, my sleep is poor, or my appetite is poor, or I don't feel very good about myself. Also, the thoughts of suicide is quite common with this diagnosis, right?
And I think those thoughts of suicide often comes with the, I guess, an antecedent of that idea of like worthlessness or hopelessness. Like you really don't see the light at the end of the tunnel.
Yeah, absolutely. And that's a really important part of the diagnosis of depression, because that's something that we do treatment planning and safety planning about, so that, the suicidal ideation, that's something that can be a part of depression. And it's really important that we talk about it. It's a normal part of, every assessment that we do. So if it's the first time you're asking, a patient that question, oftentimes, from the provider side, it can feel a little bit like, oh, what do I do? Should I ask them? How do I ask them? But if people are having those thoughts, they want someone to ask. They usually want you to know, because it's distressing. And once we ask, then we know, and when we know, we can help.
Mike, I have a question because I don't see this as much, but I have heard about this and I've seen this in some of the research. But for some individuals, and some colleagues who I've talked to, sometimes they'll say, like, before that, I guess, suicidal thought or even the act or the behavior, whether it's successful or not, that's a different story. But sometimes they'll see that a patient may actually have this sort of burst of energy. I've only heard this anecdotally from some of my colleagues, and I'm just wondering if there's truth to that, if you've seen that yourself working in the hospital environment.
Yeah, and it brings up an important sort of like myth to bust, that there was this kind of like older understanding or conceptualization about some treatments for depression,
Mm,
that they would increase the risk for suicide. And now there is still some caution of increasing suicidal ideation and suicidal thought in people under 18. That still holds true. But it's not true that if we treat depression, we're increasing the risk of suicide or suicidal behavior. In my clinical experience, kind of in the hospital or in my clinic, I don't see that. I don't see this like kind of partial recovery of function that then kind of like gives them that burst of energy that might lead to
mm,
suicidal behavior. I really don't see that.
okay.
And again, the evidence has borne out that, because there was this big shift and people were holding back the antidepressant medications, and that didn't help with the rates of suicide attempts or completed suicide. It was the opposite effect.
Yeah. And I'm just going to put a sort of asterisk out there, guys. I think given that we're talking about the topic of suicide and self-harm, I think this is, Dave, the second episode that we've touched on this in as many recent recordings. If anyone is struggling with thoughts of suicide, self-harm, please reach out for help, whether it's to your family doctor, mental health professional, your nearest emergency room. Please do reach out to a professional.
Well, you know what? We can take this in a bunch of different directions, but since we have you on as a guest today, Michael, let's maybe dive into some of the treatment options that you're familiar with that, myself and Andrew do not practice, and just to give the listeners some options. I know there are many different approaches to treating depression, but your specialization and your area of focus, I think, is really unique. And Andrew and I will touch on some of the other areas after too in another episode.
Yeah, that sounds great. So there's more treatment options than we've ever had right now in terms of different modalities. So we've got the medications, the psychotherapies, and like that you two will talk about in a future episode. Then brain stimulation, kind of in general, and there's a few of those that I'll touch on today. And then, of course, like the really important like lifestyle factors, things that we can do that are evidence based, that are helpful for our brain health and depression. I'll start with touching on medication. We did talk about this a little bit the last time I was on, but the basics with that is that we have a lot of first line options. So first line meaning there have been really robust, well conducted studies, and then they've grouped them into these guidelines that we use to kind of help direct treatment in Canada. But there's not use this one first and then use this one second, use this one third. It's just, here's a big list of options, and you have to pick the one that's the right fit for your patient. And so when you're talking to a psychiatrist, when you're talking to someone that's going to be prescribing you medications, there's lots of different options. So SSRIs and SNRIs are kind of the most common ones. And then we also have some that are variations on that, work a little bit differently. And we try to fit the specific symptom profile to the specific medication. For example, some of the medications are a little bit more activating. So give a little bit energy boost, a little bit of a cognitive boost. Some are good at helping you get to sleep and stay asleep. So we target it based on that way. And then also based on the side effects. Some medications are maybe more likely to increase weight. Some medications are maybe more or less likely to impact your libido. So we take those factors into account. And a really important thing about these medications is the timeline. So typically it takes, 2 to 4 weeks to start to see some changes, some improvements, but the full response doesn't come until, maybe somewhere between 6, 8, 12 weeks. So you're on this kind of steady slope of increasing effect over time.
And I'm also thinking, Mike, that you'll titrate the medication throughout that time. So it's not like a burst of like just one dose of the medication and you're on that the entire course of treatment.
Yeah, definitely. That's true for most of the medications that
Yeah.
it's this kind of start low, go slow, but not too slow, but do go. That's kind of the
Okay.
idea. So, and that helps, with the tolerability. Again, there are some kind of typical non-serious in the form of non like life-threatening or injury-inducing side effects to the medications, but most of them are what we call self-limiting. So they'll be there for kind of 5 to 10 days, and then those things kind of go away, and then we're just left with the positive effects. And
Yeah.
again, 30 to 40% of people won't fully respond to the first medication that we choose. And then that's where we get into kind of all of the other things that we can talk about today, and even other medication strategies. So switching the medication, increasing the dose, like you were mentioning already, Andrew, augmentation, which is where we add a different medication. So there are lots of different ways and lots of different good options that we have now to kind of optimize the impact of medications or the effect of the medications.
So I guess at 30 to 40% then, for all the listeners out there, it's like don't expect the medication to all of a sudden do wonders right off the hop. I guess what I'm hearing is like we have to be patient. We have to think about dosage changes, perhaps even medication changes. It's not like it's going to work right away.
Yeah, exactly. And giving it the time to work and working with your psychiatrist or other prescriber is part of the process, because it is a process, I guess, like you were saying, Andrew.
Mhm.
We often need some tweaks and some time.
That to me was sticking out in terms of like how important it is to have that follow up. And, for someone who doesn't have a family doctor or a psychiatrist and they're going to like a drop in Medi Center and they're going to be seen by one physician and possibly get a prescription, that really it's an ongoing process. It's not just here's one prescription and that's the way you're going to go. You might have to try different medications. You might have to try different dosages and yeah, having regular follow ups.
Yeah, absolutely. And the consults, how they work when it's kind of the one time versus the follow-up is usually they're giving, multiple steps now. It's like, start here, increase. If
Mhm.
that doesn't work, you almost have like a 3 to 4 month plan sometimes, because people are trying to do the best they can, right, in a resource limited environment. Because like you said, it's pretty common to not have a family doc or a psychiatrist that you can regularly follow up with these days.
I think sometimes that's a little bit of my frustration is that when I do have a client, whether it's a teenager or an adult, and they've started the process with a psychiatrist and they miss their next consultation, or they think, you know what, it's been a couple of weeks, it's not working, and they just stop taking it, or they start weaning themselves off or playing around with it by themselves. It's like, you have this follow-up consultation. You know what? If you have questions, like go to your psychiatrist and ask. That's why they're there, rather than playing around with it themselves.
Oh yeah, it's all I can say is I agree with that 100%. Yeah, it it's really important to have the consistency with taking the medication. And that's where, on our side of things, the education is really important. People should understand that we're not expecting it to start working in just a couple weeks, and you should keep taking it even though you might not be seeing it, because that it is part of the process.
I mean, I'm curious, Mike, just in terms of the people that come to see you being diagnosed with depression, just a ballpark, how many people are presented with the option of medication, and how many people do you maybe say, try these lifestyle changes or try therapy or try something first? Like, and I know you're going to get like a select, population, right? Like you're not walking down the street talking to the average person, you're getting people referred to you. So it's going to be different, but I'm just really curious about that.
Yeah, and again, it's also not, binary, right? Because like if someone I think would benefit from a medication, I'll tell them that. But also they need to do, not need to, they can do, and they can benefit from all of those other things, like the behavioral activation, which is just kind of like
Yeah.
our fancy word for movement or exercise, you know, getting good sleep, socialization, and and this is one thing that I think is important for everyone, just like having a reason for being. And for
Yes.
some people that's a job, for some people that's relationships, for some people that's volunteering, but having that thing that they can hold on to that gives them some, like, a sense of purpose
Yes.
is really important, and something that the medication's not going to do. But to answer your question like a little bit more directly, when I'm seeing people, I would say the majority of folks that I'm seeing that have a diagnosis of depression, I will talk to them about the option of a medication. And
Mm.
then depending on the severity of how they're presenting, there are some people where if it is like more severe and they're having what sometimes we'll call this like neurovegetative shift, where they're like losing weight,
Mm.
they're not sleeping well, having lots of those negative thoughts, low energy, I will tell them that, it's less of a, do you want to try a medication? I'll tell them, I think you should take it. These are the reasons why I think you should. So be a little bit more directive with that. Again, it's going to be their choice, but I like them to know that I'm concerned and I think they should do it. And then for some of those more, maybe, like moderate, still impacting their function, but a little bit less intense, I'll say, you have the option. Do you want to try medication first? Would you like to try the therapy route first, coupled with some of the behavioral or lifestyle activities that we'll talk about? And then, kind of leave that one with more of a maybe we will, maybe we won't with the medication.
So, Mike, when we met the last time, we had chatted about, medication in terms of helping people improve their function and especially their daily living, getting out of bed, personal hygiene, you know. And so what I'm hearing now is you were mentioning this idea of sense of purpose, right? Medication is not going to give you that sense of purpose. So in terms of let's say someone who is in a severely depressed state, like very low mood and barely getting out of bed, they're not feeding themselves properly, completely isolated and withdrawn. Would you say that medication can get them so far, but there needs to be more than just the medication in order to improve perhaps the way they feel about themselves and that sort of motivation maybe to get to work or school or walking their dog, once a day? Like, there's more, there has to be more than just medication, I'm assuming.
Yeah, and it is almost like this staged approach. Like if someone was, as sick as you're describing, the medication at the beginning is probably essential. We have to get
Yes.
people back to the point when they then can add in some of those other things. If someone is, again, hardly able to get out of bed, it wouldn't be reasonable for me to say, hey, why don't you go down to like your local pet shelter and start volunteering? But
Mhm.
once we make that seem like feasible and reasonable with some of those extra supports, like the medication or some other treatment options that are more kind of biologically focused, Then we start building in, our kind of like psychosocial supports, all of the rest of kind of what it means to have a life worth living and to be functional in society. Like those things are kind of an essential part of staying well after we can get them feeling a little better.
I feel like there's so many different entry points to try to tackle or reverse the downward spiral that happens with depression, right? Like one thing leads to the next thing, leads to the next thing. And we're looking for different ways to, either stop or switch that around. And when you're depressed, when you're feeling really low, like everything is gray and nothing feels kind of worthwhile, especially like the things that used to be enjoyable, or and so it's a really hard, especially if they've gone all the way down, like, and they're just in that dark place. It's easy for other people to say, well, just look at the bright side, or look at all, like, look at, you should be grateful for what you have. And it's like, hold on, this person is just struggling to find meaning with like getting out of bed in the morning or feeding themselves. So I, I often think it's minimized in terms of the impact, and it's often hidden where people just don't go to work or they don't see their friends or their family because they don't want to show how bad they're actually feeling on the inside. And so I just want to put that out there to the listeners in terms of like having compassion and understandings. People can look quite different on the outside than how they're feeling on the inside, and quite often can struggle for many years before getting any kind of help for this. Sorry, I went on a bit of a rant. Let's get back to our subject here.
I was gonna ask Mike actually because Mike, you had mentioned like there are other biological treatments, and I'm wondering if you might be able to introduce some of those.
Yeah, absolutely. So, one that I am kind of quite passionate about, and we mentioned briefly in the last episode, is repetitive transcranial magnetic stimulation. So, this is one of those brain stimulation methods that I mentioned off the hop. So, rTMS is a treatment for treatment-resistant depression. That's its main indication. It also has some support in, treatment for OCD and lots of experimental targets for symptoms and illness targets. What rTMS is it's a non-invasive treatment. So it uses magnetic pulses to activate circuits involved in mood regulation in our brain. There are other kind of electrical or stimulation type treatments in psychiatry. The most kind of common of which, and the one that's been around the longest, is ECT, electroconvulsive therapy, which we can touch on in a little bit. That's one that more people are aware of. TMS is quite different from ECT. So there's no anesthesia. You can drive yourself in and get the treatment. You can drive out afterwards. You're not sedated or anything like that. And it's just kind of in general less invasive than ECT, though ECT is a really important and effective treatment for some people as well.
So is TMS pretty passive, Mike, in terms of the patient's participation? It's really just sitting there and letting the magnet do its job?
So yeah, TMS it's resource intensive for the patient because for a standard TMS protocol, you come to the clinic every day, Monday to Friday, for 30 treatment sessions. So for 6 weeks, you come to the clinic. But when you're at the clinic, the actual work is done by the magnet. So you go and you sit in a chair that looks kind of like a dentist chair. There's a magnet we call it, the most common one, it's a figure-of-8 coil, and it sits above your head, just kind of like gently resting on the spot that we're targeting. And that spot is the dorsolateral prefrontal cortex, either left or right, depending on the protocol that you're using. And when the magnet is running, it's doing the work, like you said, Andrew. So the patient's job is to sit there, relax, maybe listen to a podcast, and try not to move because the targeting is important. Where the magnet is important.
Do you ever get patients who, when let's say you introduce this to them, do you ever get that look or that question, like, what sorcery is this?
All the time with good reason, because I explained it to someone one time who was like not a patient and not in the healthcare field. And he was like, "So you're telling me it's a magic wand that you wave over people's heads?" I'm like, no, no, no. There's a lot more science to it than that. So yeah, when I'm seeing people for the TMS consults, I start the consult with, what questions do you have about this? Like, do you know about it already? What have you read? So that we can then talk about it. And so, I like to tell them, like, thinking about the brain as like a series of electric circuits past that the mood signals travel through and other signals in your brain as well. And in depression, some of the circuits are underactive or kind of stuck in a low power mode. And so some of the circuits are out of balance. And so the rTMS uses magnetic pulses, which cause a little electric charge to nudge these circuits kind of back into healthier activity. So giving your brain a bit of a reboot, or to use an analogy that's very fitting in the prairies today, the TMS is kind of like giving you this fresh snowfall so that your brain is then able to change. So it doesn't have to walk the path that it's been walking every day. The snow falls and it's an open field now, and we can start to make those healthier paths, the stronger connections.
Yeah, and this is super fascinating. Like and you can fill me in on this, but the research for people that have been chronically depressed or depressed for a long period of time, how the brain circuits actually change. And we can do like fMRI where certain parts of the brain are less active than people that haven't been depressed or clinically depressed. And so it's really the science kind of catching up to, we know there's changes in the brain, and we know there's a lot of things that can change our brain chemistry and our brain circuitry, but this is one tool that is directly targeting that. So I find that fascinating.
Yeah, and when we look at the brain scans in TMS, to put it at kind of like a high level, we see these like prefrontal regions become more active. So we're turning up the power of an area that we want to. And these, what we could call maybe like emotional networks, that like reactivity, the negativity, we see those become less reactive. So they're coming back into balance. And the TMS is helping to kind of modulate or change those directly, and also inducing plasticity, which is the brain's ability to change itself. So the brain can always do that on its own, but the TMS really helps kind of like supercharge that changing or learning.
This is so fascinating, Mike, because it brings me back to like 20 years ago, my honors thesis in undergrad, looking at the dorsolateral prefrontal cortex. And you said that was actually one of the targets with TMS to work with patients with depression. And I'm just wondering, because I remember from way back then, the dorsolateral prefrontal cortex has huge implications on executive functioning with organizing, planning, shifting, initiating behaviors. So I'm just wondering, is there a significant association between depression and executive functioning?
There is a really significant
Huh.
impact. So again, going back to the fact that depression isn't only this feeling of sadness, feeling down. It has a significant impact on behavior, on function, and on how our brain functions. So you can measure the decrement in processing speed, in concentration in people that are unwell and are depressed. And so through the dorsolateral prefrontal cortex, it's part of one of these circuits that actually has deeper connections in the brain. And so it's giving us access, the dorsolateral prefrontal cortex, it's giving us access to this circuitry that we want to kind of change the volume on. And so we're giving it a little bit more power, and we're recharging the brain's ability to actually switch networks, because that's important. Our brain's ability to shift off of, say, like a good example in depression is this. Sometimes our default mode network gets a little bit too strong. So that's the one where we're internally focused, and that'll be running on overdrive, but it's also running through this negative filter in the depressed brain. So it's lots of thoughts about ourselves and lots of negative thoughts about ourselves. And so this is helping to bring the power down on that one, bring the power up on the network that's a little bit more kind of externally focused, a little bit more goal driven, a little bit more focused on the environment around us and how we might want to interact with it.
Since we're jumping back in time, I was remembering doing a bit of a practicum experience at a hospital. And one of the consults, we were talking about how they were always looking at. So one of the specializations of this hospital was like early onset dementia, but they were always looking at whether depression or dementia was happening at that time because of how the cognitive impacts of depression can mimic and affect memory and affect concentration and a lot of these things. And especially in younger people, it was harder to kind of tease those apart. And I'm actually wondering how much ruling out of other, like even just hormonal or like thyroid or just different things that you would be ruling out prior to doing rTMS.
Yeah, all of those things that you mentioned are really important. And usually when we're looking at rTMS, by definition almost, it's been called treatment resistant depression or difficult to treat depression. And when that's the case, we do look at, like thyroid, for example. We'll check to make sure that there's not, something else going on that we could treat, augment, change to help kind of improve their mood. So yeah, this is kind of in that realm of, okay, something that we tried first didn't work. Now we're looking at, what comes next. And so that, checking for other things is part of that process.
So for any clinicians listening, I guess, like really take into consideration the biological piece too, as much as we want to maybe as psychologists focus on the emotions and, the functionality of somebody, like really take into consideration someone's biology as well.
Yeah. When was your last physical? When was your last blood work? Just things like that you definitely don't want to be working on treating depression when it's and caused by something that, nutrition or, yeah. So I think, like you said, Andrew, we can get caught kind of focused on what we know and what we're looking for and understanding that the causes of depression are, multifactorial and different things can present like depression.
Well, even as we had a recent episode on brain injury, right? And this whole idea of neuroplasticity, default mode network, like Mike also brought up these terms, but also with brain injury too. Like if we think about where most people get brain injuries, it's that prefrontal cortex, right? Whether you're riding a bike or you're in a motor vehicle collision, it's that front part of your brain. So yeah, sure, the executive functioning may be impacted and someone may seem very disorganized or, really dysregulated, but now that I'm hearing this, for the first time today, how associated the PFC is with depression, like there's also another factor to consider when someone has a brain injury and they are presenting as depressed too.
Or chronic substance use. And we did an episode on, addictions. And so there's a lot of teasing apart of what's contributing to either cognitive difficulties or low mood or some of the other symptoms that go along with depression.
You don't have an easy job, Mike.
No, a good one though. It's rewarding work, but again, these things aren't straightforward usually. And when we're getting into the treatment resistance, we have to have our eyes open for what else could be at play here. And we touched on some of these things already as well, but the psychosocial dynamic of someone's life also has a big impact on these treatments. I've seen it many times as has the others in the TMS clinic. If someone's going through a ton of stress outside of the clinic, less likely that the TMS is going to help them when they're going through the treatment. So there's always other factors to kind of be on the lookout for.
I was just going to make one point that I, came across recently, and it was that these stressors, these life stressors that happen to everybody at some point, they can really trigger that first bout of depression, right? But once you've had that first bout of depression, it makes it more likely or a little bit easier for other stressors later on to trigger another bout of depression. So, yeah.
I was going to ask Mike a little bit more about ECT. Because I think many people's, I guess, first impression of ECT might be from the movies.
Mhm.
And, especially if you go back to movies from like the 70s and 80s and how scary it might appear. From my understanding, ECT has come a long way, electroconvulsive therapy.
Yeah, yeah, it has come a long way. And so it's still the most effective treatment for severe or life-threatening depression. So a depression that might land you in the hospital. It's very effective. It uses controlled electrical stimulation, but under the setting of anesthesia. So unlike some of the kind of media portrayals where like kind of that stigma and misconception comes from, modern ECT, the patient is given a muscle relaxant, they're given some sedation, and when we're looking for the seizure activity, we're looking for like the edge of their lip to be twitching, or maybe hand, like a finger twitching, or their toes twitching. So we're not seeing a lot of, there's no like thrashing. It doesn't look like a big seizure. It's done under a very kind of medicalized and controlled setting these days, and still maintains this like really, really impressive efficacy. So it's a very effective treatment that is still used very commonly in our system.
Is this repeated as well, or is it a one-time treatment?
Yeah, so an index course or the first course of treatments is usually somewhere between 12, that would be pretty standard, and maybe up to 20 treatments, but about 12
Mm.
treatments is pretty standard. And then there's some established kind of maintenance protocols. So some people just need kind of that first treatment. You only do the full 12 if you need it, if the person has improved and the depression symptoms are better. But then we can do like a slow taper off. And some people we find, with the depression that they have, it probably is what we would label as quite treatment resistant. They will continue to get ECT maybe every 3 weeks, maybe every 4 weeks, just one session. And that kind of keeps them well enough. So it's almost like this like kind of chronic illness treatment model where you just get one of the treatments every few weeks and that keeps them well.
So quite different than the rTMS, where it would be a daily treatment, in some ways less intensive, or like when I think of ECT, I think of like short after kind of memory gaps and the impact that it can have on cognition, like right after the treatment, and it's more spaced out. If my understanding is correct, yeah.
Yeah, and that's a good way to kind of compare and contrast them. So yeah, ECT, if you're in this index course, it's probably because your depression is severe or has psychotic features or is kind of life-threatening in some way. Like for example, if someone's maybe not like eating or drinking almost at all. PMS we can use in a way wider range of people in terms of severity. In ECT, you do have to be sedated for it to be done safely these days. There are some kind of short-term kind of memory gaps because we are inducing a seizure. In PMS, we don't expect there to be any impact on memory. And in fact, people will talk about how they feel that their cognitive function is actually improving during the TMS treatment. And that's probably because their depression is getting better. And like we were talking about before, that concentration and attention, all of that stuff is improving alongside. And so the ECT is a little bit more invasive, intensive for when it's needed. PMS is somewhat less intensive and invasive, but that doesn't change that PMS can be really effective for people that come in and tell me that like nothing else has worked for them. Most people get better with TMS. And about a third of people that come for a full course of TMS actually go into, again, our like research term would be remission, which is where the depressive symptoms are dropped to a point that they're not really, even if there are a few that are left there, they're not impactful or impairing.
So from what I'm gathering, we would use ECT if it's extremely severe. Like you said, the person is barely eating, drinking water. At the same time, though, I'm wondering because you mentioned like we're inducing a seizure. And I'm just thinking, again, for just the general public, when we hear like we're going to induce a seizure, like that sounds pretty significant. Like, why would we want to induce a seizure? So going back to my sort of scientific part of my brain, it's like what's happening in the brain, or how much do we know about what's happening in the brain when we are inducing that seizure in order to hope and change the course of what the person's experiencing in terms of their mood?
And, another way to think about the ECT is kind of like it's a bit of a system reboot. So you're getting, this kind of fresh start. You're getting a lot of plasticity. And there's this factor that surges in the brain when we do ECT. Brain-derived neurotropic factor, which I'll never forget. Someone described it this way. It's like brain fertilizer. So it gives your brain the ability to grow, make these new connections and change. And so it is another way that we're inducing plasticity. And the seizure is essential in that. So that your brain goes into this kind of rhythmic pattern that we measure with electrodes that we have on the person's brain while we're doing the treatment. If that's not kind of an adequate length of seizure, then we might get less effect from the treatment.
This is so interesting. This is like a computer. Like when you're talking about TMS and ECT, it's like rebooting a computer, adding in more, better power unit, like all these things, just like a computer.
Yeah, and our brain it's an electrical organ, and it is almost like a computer. It has multiple circuits. It has basically what you can think of as RAM. And we are coming up with more and more ways over time to influence that from the outside. There's more and less invasive ways, but because our brain is an electrical organ, we can use electricity to influence how it's working.
Any side effects with ECT? I know you mentioned like short-term memory can be impacted. Anything long-term though?
The memory gaps that people have in ECT is like around the time of ECT. And people will have memory issues and find them quite distressing. And so that's probably the main side effect. There's not evidence to support that people lose memories from the past from ECT. There was actually some really well-designed studies that looked at basically like people who have had ECT and people who have not and what they can recall about their past. And it was about the same. But in those people who went through ECT, their subjective experience of recalling those memories from the past was that it was worse. So they thought that they had memory loss, and so then they experienced the difficulty of recalling these old memories as this really negative thing. Whereas the people who hadn't had ECT had the same memory lapses from the past, but just didn't experience them in the same way.
I could imagine the same thing could be said about medication, right? If someone has a symptom or has something happen and they're wondering, well, I think the medication caused this. Like it's hard to kind of tease apart, is this normal kind of progression in terms of maybe slower cognitive functioning or memory issues that happen gradually over time? Or is this caused by a treatment that I'm trying to improve things with? And yeah, we're always looking to where we attribute the cause of things.
This is such an interesting discussion. Beyond ECT and rTMS, any other treatments, Mike, that sort of touch on the biology of the brain and how we influence it from the outside?
Yeah, so in keeping with the stimulation type treatments, there are a few more that are kind of emerging technologies, some that are kind of at varying stages of investigation. So the TMS is done, with this magnet that pulses. There's something a little bit different called direct or transcranial direct current stimulation, which is basically a direct current. So we get it from a battery, and you put an anode and a cathode, so the positive and the negative at different places on the head, and then you run a low amplitude current between those two things. And depending on where you place them, you're impacting a different part of the brain. And that is something that's being investigated for treatment-resistant depression as well.
I can't help myself. Yeah, correct me, but I think some of this is like do it yourself at home happening on like I've come across some people running like electricity currents through their body for different ailments, and I'm like, So there's some science to this, but there's also some like probably pseudoscience that's happening out there.
Yeah, that's a good summary of it. So there are FDA approved compliant devices that are, kind of rigorously studied, but there are also these kind of like cosmetic psychiatry devices out there. There's lots of wellness companies that have some of these devices out there that are really interesting, kind of neat looking things that where the evidence I think is a little bit kind of mixed on what they're doing. For example, there's one that's meant to make people train better. So it's like stimulating the motor area. So then if you're a high performance athlete, you wear this thing and then you do your tennis practice and it's supposed to make you kind of pick it up a little bit more quickly. There are some that are meant to kind of help with stimulating creativity, things like that. So not with a full kind of stamp of Health Canada approval, but there definitely are some things that you can look at on the internet for that. The transcranial direct current stimulation, though, is one of those, like there are bona fide devices, there's research trials, there's lots of work going on in that area. There's also vagus nerve stimulation. So actually it was a treatment for epilepsy first.
Mm.
And the original devices are implanted. And so you wrap a coil around a nerve called the vagus nerve, which is a really important nerve in kind of sending signals back to the brain. And then you kind of modulate the activity of that vagus nerve to help with treatment resistant depression. There are also new devices in that realm that don't require a surgery or an implanted device because you can access parts of the vagus nerve or at least get signal to it through some like devices you would wear around your ear, for example, that are stimulating some of the nerves around there that are connected to the vagus nerve. So that's also a growing area. And then there's the device that's been around for a long time, more recent years being looked at for depression and other psychiatric indications in the form of deep brain stimulation. And so again, investigational research trials only right now at this point for depression, but it involves a neurosurgeon implanting probes in specific parts of the brain and then using the electrical signal again to try to kind of modulate things that way. Its most kind of prolific and common use case is actually in Parkinson's. And so that's then been kind of shifted to other brain ailments.
That's the thing I find fascinating about medicine. I know most of it is evidence-based, and it's like we just sort of stumbled upon, like you said, like it was treating Parkinson's, and it's like, whoa, hold on, it's also helping mood and depression. And so let's move with that. That I've always found that to be so fascinating. It just happens that way.
Yeah. Yeah, there's lots of cases like that in medicine. You're right.
Actually, this, as you were talking, I'm thinking about like the placebo effect, and we haven't really talked about this, but in terms of how when we think something is going to help us, that it actually has a 50% or there's a significant amount of improvement that can happen. So I know you're talking about some of these almost like cosmetic interventions that look really cool and seem pretty high tech. And that might actually just shift the thought process around like, now I'm going to eat better. Now I'm going to exercise more. Now, like, because I'm getting this treatment. And I'm curious about rTMS in terms of like ruling out or checking to see how much of the effect is not placebo effect. Like, do they have randomized controlled trials where, yeah, the thing's on the head, but it's actually not having any magnetic resonance?
It's such a good question. And placebo effect, that could be another episode. There's some really cool research in that area. But effectively, yes, there are really well designed trials to make sure that the effect from TMS is actually from the electricity, not just from like going into this clinic that has this cool looking machine and lots of people around, because that helps, right? Like that is part of the effect, but that's not the only part of the effect. And I don't think that placebo is like a dirty word. We should harness it and use it. People should come in and feel like they're being well cared for. And I'll let them know this treatment works for a lot of people in a very similar situation to you, so like instilling hope that this can work. And I'm not blowing smoke. It's because it does. Like I see it work for people all the time. But the patient believing that is important too.
Mm-hmm.
They've done trials where they have sham coils or even the same coil that they would use to treat depression, but they flip it upside down so that, it's well blinded. The patients don't know if they're getting the treatment or not. And in those like sham controls, which is where we look at how much is, you're in this room that looks like it could be on a spaceship versus how much is from the electricity. And we do get a good effect from the treatment for TMS. But yeah, the placebo effect in all areas of medicine, psychiatry, it's more prominent in news and in research, but it's a really interesting area.
Well, similar to psychology, right, Dave? Like you have to have that buy-in, as you mentioned, Mike. Like if you go into a therapist's office and you don't feel motivated, you don't feel like there's a good connection with the person, like the outcome is probably not going to be so good. So like that ability to go in there and say, okay, I believe in this, I'm going to really give it my best shot, makes a big difference.
Well, and within the context of depression, right? Like another way to look at depression, or the way it's been framed, is like this learned helplessness, right? So we actually start to believe that no matter what we do, it won't matter, it won't help. And to be able to shift that and go like, oh, there's a new treatment, or there's something that I can do that might be able to help me, that can be huge. So someone, like you were saying, Andrew, like someone coming into our office and they're like, well, my friend had this type of therapy and it helped them, and I want to try that type of therapy. I might know that it's just as effective as three other types of therapy, but let's do that one because this person feels like this will be helpful. And that's great, right? That can be the initial kind of like Mike, what you were talking about, the fertilizer on the brain, right? Like some new circuits that can start to get activated that lead to other lifestyle changes, social changes, like those key things that are so important. But what's going to start that?
So, Mike, again, I mean, having you on has been so fascinating, even on a personal level, like just learning about all of this and digging deep back into the neuroscience background. This has been really, really such a fascinating discussion. And I think I've used that word like 3 times now. So we're so happy that you came back, and even there was a comment asking you to come back, to talk more about TMS. So that was really neat. So I guess with just being conscious of time, I want to go to our conclusions, and Dave, I'm just wondering, what can you take away from today's discussion in terms of all these really cool technologies in terms of treating depression?
Yeah, I think that's where I'm at. It's a lot of hope. There's new treatments coming out. There's different ways to approach this. So if you are struggling and you're feeling like, nothing will ever get better, I know it's hard, but just keep trying, keep reaching out, and hopefully even just someone listening to this will be more motivated to try something more and eventually lead to improvements and feeling better. I think this is the biggest downside on humanity is depression and suicide, right? Like it's just our human resources. There's so much potential that gets lost because of the way people are feeling, and they can't be themselves and they can't live their life that they, like you said, that the life's purpose. It's sad to see. And I'm hopeful that there are ways to help people, yeah, with this.
I think for myself, it's just knowing the hope and the promise that there are people doing amazing work behind the scenes, trying to figure out just new and other ways, whether it's improved. Yeah, maybe there are improved ways too, but other ways to treat depression and mental health disorders. And that there's a lot of science going into it and different varieties of treatments. So just holding on to that hope and that promise that, it'll work for something will work for different patients out there. Yeah. And Mike, anything for you? I know you're deep into this field, but even just talking to us today, anything, any final message?
Yeah, just to carry on what some of you guys had already highlighted, that there are a lot of options. We have more tools than we've ever had before, and we can try different things. We can take different approaches. As a field, we're innovating, and so as individual psychiatrists, providers, we can try a lot of different things for that patient who feels like they've tried everything. So there is a lot of, to use your term, hope and promise in the field.
Amazing.
And I think it starts with asking for help a lot of times, right? So there's so many people suffering that are not getting any help because they're not even sharing that they're struggling. So once you ask for help, then there's a lot of options that you might be able to try.
Mike, thank you so much for being on our podcast again. We're going to have you come back about placebo effect now that you brought it up.
Thank you guys for having me on again. This has been great.
Yeah, thanks so much. This is a pleasure, and I appreciate you taking time away from your day and sharing your wisdom and understanding with the broader public. So thank you so much.
Thank you. Take good care, everyone.